what I've just done here is drawn out the posterolateral aspect of the knee. Here you can see the lateral border of the patella, Gerdy's tubercle, the joint line, iliotibial band represented here coming down towards Gerdy's tubercle. This is the biceps tendon inserting onto the fibular head, and of course the anticipated course of the perineal nerve coming down here. So I did this dissection before the end of your last session, just in the interest of time. So we're just going to pop some sutures here and show you this dissection, and then you can have at it in the lab. So I've just taken all of these sutures. The anatomy, of course, here is fairly simple to discern early on, and simply by, Tim, would you mind retracting that? Simply by elevating these skin flaps, we immediately start to identify the biceps tendon coming down, the fibular head, the anterior compartment fascia, and certainly the iliotibial band that we see over here. This is where you're going to first pick up the perineal nerve. I think if you pick up the perineal nerve here, it's quite straightforward. There'll be a layer of fascial and fatty tissue here that necessitates you to be spreading some of these tissues, but there you're going to identify the perineal nerve. As you come down to the perineal nerve, it will rapidly become tethered along the proximal part of the fibula here at the fibular neck. I've just taken a stitch and placed it in here. But one of the simplest ways I think that you can mobilize the nerve safely is to incise this fascia proximal to the nerve and then take down the musculature off the neck with the nerve. And so all those arborizations stay with the muscle, and I think it helps prevent you from doing any kind of over distraction. You can also mobilize it down in here and leave it within the substance of the musculature. That's a pretty good way of doing it. Almost immediately, once you identify the perineal nerve, you easily identify the lateral head of the gastrocnemius musculature, and then the soleus is immediately anterior to it here. And so it's easy to find this interval, the soleal lateral gastrocnemius interval. And if we lift this nerve up and retract it, Tim, I'd appreciate that. And then as we take down the soleus, as you saw in the photographs there, off the posterolateral aspect of the fibula, with a little bit of internal rotation, hopefully what I can show you here is, here's popliteus coming up and becoming tendinous. I don't know if you can see that, but we immediately come into the posterior aspect of the tibia. So here's the tibial plateau right here. Remember, the top of the fibula is below the level of the articular surface. So all of this that you may, so what we here have is the back of the fibula here, and all of this that my elevator is on the posterolateral aspect of the tibial plateau. Excuse me. And if you look right in here, we'll see the neurovascular, or sorry, the vascular bundle starting to course in, perforating the interosseous membrane, sort of in this anticipated 3 to 5 centimeter zone from the top of the joint surface. And so this is a small footprint that you can go ahead and apply a small plate into this area here. But as you can see, it's really hard to, you can't really see anything in here other than the posterior cortex. And so if you combine this approach with your typical lateral-sided arthrotomy, and I've gone ahead and mobilized the iliotibial band and done a submeniscal arthrotomy here. If I can just give this a little bit of varus, I might be able to get into the joint surface here. So now this is inside the joint. I don't know if you guys can see that here, but now I'm inside the joint surface, essentially around the back of the joint. Now this is where my exit point is here now. And so this is how you can see your reduction up in here, and if needs be, you can put a small little implant, little buttress plate that you might find off of a hand implant set, or some other small malleable type of sets that you might see in a foot modular set or something like that to help hold that. But this is the approach, and if there's time allows, you can go ahead and try to do your fibular osteotomy right through here and release the anterior capsular ligaments, osteotomy. As you elevate it up, continue to release the posterior ones, and you'll see that whole posterolateral corner of the proximal tibia.